And today, it's quite an interesting paper, and this was in 2020. And what it was looking at is, does age matter or does AMH matter? So let's look at the aging process, and the aging process is very much different to the aging of the ovary. And the ovary ages much earlier, and it is ethnically oriented as well as genetically oriented. So what did they want to look at? They looked at those who have a decreased ovarian reserve. And we know that about 67% of women who come in for treatment will have a decreased ovarian reserve. Now, what we also know that figure goes up to almost 40% in women when they cross the age of 40, indicating that stimulation becomes more difficult. So what were they looking at? They're looking at what are the parameters by which we check for pre-assess somebody who is going through IVF. One is AMH, age, antral follicle count. And so the criteria which they had in this case was that they had reserve as less than 1.1 nanogram per ml of AMH, shorter menstrual cycles, and an antral follicle count of less than 7. Now, they excluded in the control group those with medical disorders and polycystic ovaries. So if you have a look at the result, what they did find out that the number of oocytes, the number of mature eggs, the number of blastocysts, and the number of available embryos were less in those who had a decreased ovarian reserve. And if we again looked at the live birth rates and the clinical pregnancy rates, they were lower in those with a decreased ovarian reserve. So if you looked at the non-decreased ovarian reserve, the live birth rate was 49.3%, while that on the decreased ovarian reserve was 37.3%. So you'd say, yes, there is no doubt that there seems to be a decline in the live birth rate when you have a decreased ovarian reserve. But here again, when they split up the data, they saw that if you put a single blastocyst back, there wasn't a much statistical difference in the live birth rates in both the groups, which basically means that the quality of a top quality embryo was very, very similar. Next, they looked at what happens after pregnancy, and they saw no significant difference in birth weights, gestational age, delivery, gender, or abnormal perinatal outcomes, indicating that low AMH, at least in this study, did not have any impact on the perinatal outcome of the patients. And that is again quite interesting. So why is this study important? Because if you have a low ovarian reserve and a patient comes to you with a low ovarian reserve, we are often go very negatively about it and tell a patient that, well, it is a possibility we will not get any eggs. But what we also know is that age matters, and even though clinical pregnancy rates would go down and live birth rates will go down, there is a reasonably good chance of a live birth rate even with a low ovarian reserve. Now, what we know is that low ovarian reserve is associated with quantity and less to do with quality. Now, there's also very little evidence suggests that low reserve in young women is linked to miscarriage or increased biochemical pregnancy. And we have to reassure women that if their reserve is low, we certainly warn them that the number of eggs obtained would be less and number of embryos less, but they still have a reasonably decent chance of pregnancy, though at a slightly lower level. And that should give reassurance to some women with a low reserve to embark on treatment with their own eggs. Thank you very much.